When we get that advance notice from EMS, we're able to alert our stroke team and be prepped and ready as soon as that patient rolls in the door.
Suspected stroke patient?
Let's move him straight to the CT suite.
The initial evaluation should include assessment of the patient's ABCs: airway, breathing, and circulation. Hospital personnel should administer oxygen if the patient becomes hypoxemic while en route. It is best practice to bypass the emergency department and take the patient straight to the computed tomography, or CT, or magnetic resonance imaging, or MRI suite. Hospital professionals should assess a patient with a suspected stroke within 10 minutes after the patient's arrival in the emergency department, CT suite, or MRI suite. Follow your local protocol. Data collection is the next D in the 8 Ds of stroke care. The collection of diagnostic data should occur within the first 20 minutes after the arrival of a patient with suspected stroke.
Hi, Mr. Johnson. We're going to take care of you. Let's get an initial set of vitals, order of blood glucose, electrolyte, CBC, creatinine, and coagulation studies, and then finish setting up for the CT scan of the head.
Got it.
Confirm IV patency and draw blood samples for blood glucose, electrolytes, CBC, creatinine, and coagulation studies. Even though EMS did a fingerstick blood glucose analysis, hospital personnel should review and verify blood glucose results.
Mr. Johnson, can you raise your arms for us? Okay, Nancy, what's his blood pressure?
It's 190 over 112.
Okay, let's set up an IV infusion of labetalol per our protocol. Let's try to get his systolic blood pressure down to less than 185 and his diastolic down to less than 110. And then we'll recheck that about every 3 to 5 minutes.
Okay, right away.
The studies are clear. We need to evaluate the patient and deliver treatment as soon as possible. Even short delays can have a negative effect on the patient. Our goal is to have the physical assessment and the CT scan evaluation completed within 45 minutes of the patient's arrival to the hospital. Now, CT scans can help us rule out a hemorrhagic stroke and determine the best treatment path for the patient. And getting detailed information from EMS allows us to have the imaging station or the cath lab ready and a neurologist standing by.
In addition to conducting a National Institutes of Health stroke assessment and getting labs, hospital professionals should also acquire a 12-lead electrocardiogram, which may identify a recent myocardial infarction or arrhythmia as a potential cause of the stroke. The final link in the stroke chain of survival is rapid diagnosis and treatment in a hospital equipped for patients with acute stroke. This is also the 6th D in the 8 Ds of stroke care: decision regarding treatment.
What are you seeing on Mr. Johnson's CT scans?
I don't see any evidence of hemorrhage.
He came in about 25 minutes ago, which is well within our window for thrombolytics.
I agree. I did another NIH neurologic exam and he showed no signs of improvement.
So do you think it might be a large vessel occlusion?
Very likely. I'm ordering a CT angiography to confirm, but let's go ahead and prep this suite and have staff on standby.
Sure.
Let's pull our IV thrombolytics and begin to prepare according to our protocol. Labetalol infusion has been started, but we will need to get his blood pressure down below 185 over 110. I'll go speak with the patient and family to update them on the diagnosis and treatment recommendations. Verbal informed consent is an important part of the process. We don't want to delay initiating treatment. Time is of the essence.
Yeah, sounds good. We'll continue monitoring his blood pressure.
Before pursuing any treatment, it's crucial to check the patient's history for any pre-existing conditions or contraindication to the drug therapy. These include previous brain hemorrhage, prior stroke, recent bleeding anywhere, history of blood clotting problems, recent surgery or accidents, and prescription medication contraindications. The next D in the 8 Ds of stroke care stands for both drug and device. For ischemic stroke, IV thrombolytic drug therapy provides substantial benefits if given within 3 hours after symptom onset. Although this class of drugs can improve the chance of recovery by 30%, these drugs also have a 5% risk of causing a cerebral hemorrhage. Patients who present with large vessel occlusion may be candidates for endovascular therapy. This procedure should be done as soon as possible, but can be performed up to 24 hours after last known normal.
Mr. Johnson's angiography confirmed what I suspected, a large vessel occlusion. We prepped him for endovascular therapy. During endovascular therapy, a guide wire is fed through the clot, followed by a sheath. The guide wire is then removed, and when the sheath is pulled away, coils are deployed within the blood vessel, crushing the clot and restoring blood flow immediately. The coils are then removed from the blood vessels, bringing the clots with them. If endovascular therapy is not available, eligible patients should be transferred to a facility qualified to perform it. The procedure is best performed as soon as possible.
For optimal stroke patient recovery, hospital professionals must carefully control the patient's blood glucose levels, temperature, and blood pressure. The final D in the 8 Ds of stroke care is disposition. This means rapidly admitting the patient to a stroke unit or critical care unit.
Thanks for being there for me, son.
Oh, you're welcome, Dad. We need you for the next gig.
These specialty units provide best practices for stroke treatment and significantly improve outcomes for post-stroke recovery. When there are strong links in the stroke chain of survival, rapidly recognizing the signs of acute stroke, rapid EMS dispatch, rapid EMS transport and notification to the receiving hospital, and rapid diagnosis and treatment, patients with stroke have been shown to have the best chance of recovery.